We'll go ahead with the session. And can I first invite the first speaker, correlating degree of nuclear density and of FICO and post-op outcome in age-related cataract. Excuse me. Dr. Manendra Singh. Dr. Manendra Singh, is he here? Is not there?
Please call the next person.
Yeah, we'll go ahead with the second one. Can I invite Dr. Nabarun Dar? Nabarun Dar. Okay, we'll go for the third. Professor Aparajit Chowdhury.
Aparajita Chaudhary.
Sorry, Professor Aparajita Chowdhury. So I'll do the other way around. Who is there? Just let me know. Who are the speakers present here? Dr. Rupam Janak Desai. Can you please come over? She would be presenting on active centric handpiece and ozil handpiece comparison in phacoemulsification with active fluidics.
Good morning, everyone. My topic is comparison of active-centric handpiece and ozil handpiece in phacoemulsification with the active fluidics. As you know, everyone, the cataract is the cause of global blindness in 51% of the cases. Phacoemulsification is the choice of the treatment. Previously, the most phacoemulsification, they were gravity-based. And when there is a difficult situation, it becomes again a challenging task. So the new technology has come up, which is called active fluidics. This system of active fluidics approaches the stability of the anterior chamber in a different manner. There is a compartment into which a bag of BSS is placed between two paddles. Very small and precise movement of the electronically controlled paddles against the bag, they are designed to lead to exquisite control of the fluid entering the eye. The control is the part of technology called active fluidics, which allows the surgeon to choose a target IOP. This ultimately gives you a stable anterior chamber, less surgical time, less ultrasonic energy, greater followability. This ultimately translates into the clearer corneas and the lesser anterior segment inflammation on the next day. Now, what is active centric? The sensor here to control the set the intraocular pressure, it is called a target IOP. In active centric handpiece, it measures the target IOP very nearer to the tip by integrated pressure sensor, so eliminating the millisecond delay in adjusting the fluidics. So the combination of active fluidics and the active centric handpiece, both, they reduces the possibility of surgeries by almost 50%. So maintaining the stable anterior chamber at the lower intraocular pressure makes the experience more comfortable for the patient too. So we decided to do a study whether there is any difference between two phaco handpiece in intraoperative parameters, postoperative parameters with the preset IOP in different cases. So we did a prospective non-randomized interventional observational study. We use a centurial vision system with the grooved sleeve and balanced tip in both the groups with the preset IOP of 30. Analysis of the intraoperative metrics like phaco energy, phaco time, and the fluid required was done. Analysis of the post-operative outcome like day 1 visual acuity, intraocular pressure, slit lamp was done. Endothelial cell loss was counted, and the comparison was done in both the eyes. Statistical analysis was done in the pair t-test with the independent t-test and the one-way ANOVA test. We set the target IOP of 30, which is equivalent to the bottle height of 41, which is closer to the physiological level. We set the irrigation factor of 1.2 to compensate the wound leakage. The selection of this target IOP offers a wide range of fluidics options in various types of cases and maintains a stable anterior chamber. These are the settings for both the groups. So we compared the CDE in the different grades of cataracts and we found there is no significant difference. But the similar study was done by Professor Jiraskova, shows a reduced CDE in active centric group. And the similar study was done by Cyril Dhyana, also concluded that CDE was less for the soft cataract in the active centric group. Then we find out a comparison of aspiration time in all the cases, and there is no significant difference in the aspiration time. We did a comparison of fluid usage. It was significantly less in the grade 2 and grade 3 cataract in our study. The similar study was done by Jiraskova. They show there is no significant difference in fluid usage. We compared the endothelial cell loss, which is significantly less in the active centric group in all grade of cataracts. Active mitigation in different cataract grades, we noticed it is a significant difference in different grades, but this ASM was more activated for the soft cataract. Cyril Dhyana also concluded that ASM was more activated for the soft cataract. So, similar study was done, that is a comparison of real-time intraocular pressure response to the occlusion break event in the two phacoemulsification system done by Dr. Vasavda et al. They shows there is a rise of IOP was significantly higher in active centric groups, suggesting that there is a faster recovery to the baseline IOP after occlusion break. We did a comparison of post-operative visual acuity. There is a significant difference between the two groups, which is good in the active centric group. The similar study was done by other authors. They shows there is no significance. Post-operative day 1 slit lamps and intraocular pressure measurement were comparable in both the groups. So we concluded that working with the active centric handpiece gave an advantage on operating mainly in the soft cataract, which might lead to post-operative occlusion surge via chopping, as it is prevented by the new sensor technology and gives the good result. Precise maintenance of the set IOP, ensuring the higher stability of anterior chamber even upon the higher vacuum values, significantly reduces the endothelial damage. Just in the same way, automatic braking system respond faster than the drivers, the Alcon system respond faster than a surgeon to prevent a surge. So to conclude that active centric along with the active fluidics allows the surgeon to work at the low preset IOP, which is closer to the physiological level without fear of anterior chamber surge, and it provides the better intraoperative safety, post-operative outcomes in all eyes, and it is more relevant in cases with myopia, small pupils, glaucoma, and cases with a poor endothelium. Thank you.
I am KPS Malik and I welcome you all. And I think two speakers have not come. First, 2, 3 are not there. So you have done well, beta, and I just you were controlling them all. Your pressure, IOP pressure was always less than 30 or what? Or
So we use a target IOP of 30 in almost all the cases.
30.
Yes, 30.
Thank you.
Yeah, thank you.
Thank you. Please call the next speaker.
Can we have Dr. Nisha Bharti? Is she here? Okay, we'll move on to Dr. Saurabh Kura. Please come on to present comparative study between phaco-capsulotomy and needle aspiration in white intumescent cataract.
Good
morning to all my teachers.
What is that?
I'm
Why
a
NNI?
second year postgraduate from Bangalore. So my topic is comparative study between phaco-capsulotomy and needle aspiration technique in white intermittent cataract. So phaco-caps emulsification has become a standard technique. So no step is in contemporary cataract surgery is as important as anterior capsulorhexis. So white intermittent cataract constitute a significant volume in our practice, and surgical technique is very important. So capsulorhexis can be difficult in these eyes because of compromised red reflex and high interlenticular pressure. So hence the rhexis has an inherent tendency to run out to the periphery. So when this occurs, the appearance of a stained anterior capsule besides the white cataract mimics the blue pattern of the Argentinian flag. So it was named as Argentinian flag sign. So this may progress to complications like zonular dialysis, posterior capsular tear, and vitreous loss. So different methods have been tried to prevent the uncontrolled extension of capsular rhexis. That is needle aspiration, which is standard technique, two-stage technique, femtosecond laser assisted capsulotomy, and phaco-capsulotomy, which is a novel technique. So multiple studies demonstrate how safely to do phaco-capsulotomy, but there are only few studies which compare it with other techniques. So here we intended to conduct this study to study the efficacy and safety of phaco-capsulotomy and needle aspiration in white intermittent cataract. So our objective was to compare efficacy and safety between phaco-capsulotomy and needle aspiration in terms of intra and post-operative complication, and to compare the post-operative visual outcome between these two techniques. So 60 patients diagnosed with white intermittent cataract were selected in this prospective study. So 60 patients were divided into 30 each randomly. So group 1 was phaco-capsulotomy and 2 was needle aspiration. So phaco-capsulotomy is a novel technique where phaco tip is introduced into the anterior capsule and the liquefied cortex is removed, thereby reducing the intralenticular pressure. Whereas in needle aspiration, a 26.5 gauge needle is introduced into the anterior capsule, thereby depressurizing the nucleus and helps in controlled capsular rhexis. So statistical analysis was done by chi-square test and Fisher exact test, analyzed by SPSS version 20. And inclusion criteria was only white intermittent cataract. Exclusion criteria was cataracts with corneal opacity, glaucoma, iritis, and suspected retinal diseases. So all these individuals satisfying these criteria, after enrolling into the study, a detailed history of the patient was taken, and individuals were subjected to general physical, systemic, and thorough ocular examination. So intraoperatively, here we were observing for elevation of flap and continuation of rhexis, radial extension of the rhexis, discontinuity of rhexis, any decrease in the intralenticular pressure, in total decompression for assessing the leakage of liquid cortex, and the centration of capsular rhexis, posterior capsular rupture, and vitreous loss. Post-operatively, we look for corneal edema, iritis, raised IOP on day 1, first week, first month, 3 months, and 6 months. So intraoperatively, flap elevation was noted in all the cases in phaco-capsulotomy, whereas only in 80% cases of needle aspiration it was seen, and extension into periphery was seen in 3% of patient and 30% in needle aspiration. Centration of capsular rhexis was almost in 97%, which is more significant than 73% which was seen in needle aspiration. Decrease in intralenticular pressure was noted in 67% in phaco-capsulotomy and 40% in needle aspiration. Posterior capsular rupture was seen in 7%, whereas PC rupture was significantly seen in needle aspiration, that was 27%. Vitreous loss was not at all noted in phaco-capsulotomy, whereas in 7% cases it was noted. So post-operatively, which was not significant, corneal edema was seen in 7% in phaco-capsulotomy and 17% in needle aspiration. Iritis was noted in 3%, whereas iritis was not noted in needle aspiration. Raised IOP was seen in 3% of cases in capsulotomy and 10% in needle aspiration. So coming to the discussion, so when we compared our study with a few similar studies, flap elevation that was seen 100% was similar to 100% which was seen in a similar study. Extension to periphery was also noted in 27% and 2% in similar studies. Centration of rhexis was noted in 62% and 71% and 88% respectively. Decrease in intralenticular pressure was also seen in 88% in a similar study. Posterior capsular rupture was seen in 5%, 1.8%, and 2% in the similar studies in phaco-capsulotomy, whereas in needle aspiration, this was also significant when compared to the similar study. Corneal edema was also noted in 7% cases in our case study, and it was similar in similar studies. So during capsular excess, there was more tendency of the edge to capsule to go into periphery in 70% cases. So centration of rhexis was found in 97% cases, and success rate achieved for capsular excess using phaco-capsulotomy is assumed to result from controlled aspiration and increased safety when compared to needle aspiration. Chakraborty et al. Also showed incomplete capsular excess in 29% cases. A posterior capsular tear was seen in 2% cases, and conversion to manual non-capsulotomy cases were done in 2% of cases using needle aspiration. Vasavada et al. Examined in 60 eyes with senile mature cataract in which small rhexis was attempted initially. The rhexis was enlarged before intraocular lens. Yes, sir. Yes, sir. So I'll come to the conclusion. Yes, sir. I'll come to the conclusion. Yes, sir. Yes, sir. Coming to the conclusion, phaco-capsulotomy technique is a simple, controlled, and effective technique that extends the possibility of routinely achieving capsular excess and thus preventing Argentinian flag sign in white intermittent cataract than needle aspiration technique. Thank you.
Area of the capsule which is free of the zonules. Where zonules start and
5.5.
5
to 5.5.
Yes, 5 nearly, and then zonules start from there and then go on becoming dense and dense. So if your capsule goes into dense area, then it will run away.
It will run away.
And I have published a small one, bimanual rhexis. If you find it somewhere, contact lens and ophthalmology somewhere, I'm very poor in writing. But you have a bimanual means your left side you have your dialer and right side you have a needle. So that way you guide the rhexis by the left hand. So make it nick and then start guiding it. The fluid will come itself. Of course, I use the anterior chamber maintainer in all of them. So anterior chamber maintainer keep the pressure down and it won't allow you to run it away. But overall, these cases, whatever you do, it will run away somewhere, whatever you do. You cannot stop it. But what I do, suppose it becomes Argentinian flag, you make the another rhexis small one, half moon, and half moon other side. So your bag will still become intact. If you make the two small rhexis, here and here, or anywhere on this ruptured one, you can still make the bag intact. I think this is for, thank you so much.
So may I ask a question?
Just one, yeah.
Have you been in operation theater and seen how these two techniques are done?
Yes, sir. My guide was.
He was doing? Okay. So tell us how phaco-capsulotomy was done.
So phaco-capsulotomy, we basically, phaco tip is introduced into the center of the anterior capsule and the power of phaco-capsulotomy is introduced into the anterior capsule and power of 200 and aspiration flow rate of 28 cc per minute was maintained. And the phaco machine was placed at position 2 where I&A was done. After that, the sculptop
How
was...
the capsule was ruptured? Was ultrasound used at that time?
Sir?
During initial, how was the anterior capsule was ruptured? I mean, anterior capsule has to be initiated, no? The tear has to be initiated.
Yes, sir.
By the phaco handpiece. How was it done? How was the tear initiated?
Tear was in the center, sir, up to 80%.
So you just pierce by the phaco needle, the
Yes,
central
sir.
part?
Yes, yes.
Phaco needle is quite thick and it is not so sharp. So how can you pierce that without using ultrasound?
Not used ultrasound, sir.
So you have not probably seen the technique minutely. First, a burst of energy has to be used to, to tear off the central part of the capsule. Otherwise, if you just push it, it will not cause any tear. Right?
Yes.
And also in your complications, you have mentioned the rate of cell loss and corneal edema is more in the needle aspiration compared to this thing.
Yes.
So logically, I can't understand. How do you explain that? Because only when there is a phaco there is a chance for extra cell loss. When you are doing with a needle, at least it has to be comparable. I don't think it can be more. Is there any reason why do you think it was more in your case?
There was no reason.
And you used a 26 gauge needle. It doesn't
26
aspirate any matter actually. You have to use at least 23 gauge or something like.
आपकी गाइड है यहाँ पे?
Because of,
Your guide is here?
no sir.
गाइड को पूछेंगे ना, आपको क्या पूछे? They're good beta, but your corneal edema basically depends on the how much phaco power you use. And if you, it's nothing to do with the capsulotomy, how you did it. With they can be done with phaco tip also, it can be done with needle also, it can be done with so many methods. But edema is dependent on your phaco time, basically. And so that is basically, everybody knows that phaco time is directly proportional to phaco edema of the cornea. Thank you. Thank you, please. Next one.
Do we have Dr. Alpesh Toprani?
No? No one?
No.
Longitudinal and torsional. Torsional, of course, gives the better result. So we combine both, but again, depends on how much time you use for phaco time, basically phaco time, for every one of them. So OZIL is not something boon-like, but it does help a little bit because you have side-to-side movement and not the direct one.
Do we have Dr. Mridul Trishal? Please come. He's going to present on analysis of surgically induced astigmatism after 2.2 millimeters versus 2.8 millimeters incision in phacoemulsification.
Should I start? I'll start. Good morning, everyone. I'm Dr. Mridul Trisal. I'm a third-year junior resident from Subharti Medical College, Meerut. My topic is the analysis of surgically induced astigmatism with 2.2 millimeter versus 2.8 millimeter incision in phacoemulsification. Cataract surgery has progressed from the ancient practice of couching to the modern technique of micro-incision phacoemulsification, aiming to offer the safest, simplest, and the fastest procedure with minimal post-operative astigmatism. The concept of refractive cataract surgery is becoming increasingly significant in the present time. The advancements in cataract surgery techniques have resulted in a notable decrease in incision sizes from 12 millimeter for intracapsular cataract extraction to 10 millimeters for conventional ECCE to 6 millimeters in small incision cataract surgery and currently to 2.2 to 2.8 millimeter incisions in microincision phacoemulsification cataract surgery. Smaller incisions offer several advantages like sutureless surgery, enhanced wound stability, and decreased corneal abrasions. It is known that surgically induced astigmatism, SIA, may decrease uncorrected distance visual acuity and require refractive correction, which may decrease patient satisfaction after the surgery. In order to minimize surgically induced astigmatism, reducing the incision size is considered an important aspect. The aim of my study was to assess the visual outcome and magnitude of surgically induced astigmatism in 2.2 millimeter and 2.8 millimeter superior clear corneal incisions in phacoemulsification and to compare and analyze the SIE between the two groups. This prospective randomized interventional study was conducted from February 2023 to March 2024, included 300 patients undergoing uncomplicated phacoemulsification cataract surgery with foldable PCIOL implantation and were randomly divided into two groups, Group A of 2.2 millimeter incision and Group B of 2.8 millimeter incision, both having 150 patients in each group. The study included patients of either gender with senile cataracts, the patient's age being more than 40 years, having preoperative keratometric astigmatism of less than 1 diopters. Slit lamp examination, keratometric measurements, and refraction were performed preoperatively and were followed up postoperatively on day 1, post-op 1 week, 3 weeks, 6 weeks, to assess the visual acuity and the surgically induced astigmatism at each visit. These are the pictures of phaco surgery being done in one of the patients of my study by my guide, Dr. V.K. Malik sir. The results and observations. Distribution of patients was 150 in either group. If we compare the mean age, it was comparable in both the groups and with no statistical difference. If we both the groups had more number of females than males, but there was no difference in between the groups A and B. If we compare the laterality of the eye, both groups had more right eyes, but there was no statistical difference in that. Then when we compare the uncorrected visual acuity between the groups at postoperative week 6, we see that more patients in group A, that is the 2.2, have 6.6 and 6.9 vision, whereas slightly fewer number of patients in 2.8 millimeter incision have uncorrected 6.6 and 6.9 vision, indicating those patients require refractive correction to attain that vision. This is a bar graph showing the similar data. Then we have the best corrected visual acuity. In this we can see both the groups 2.2 and 2.8 have comparable 119 versus 112 patients with 6.6 and 6.9 vision, showing both the groups have comparable visual outcomes. Then if we compare the surgically induced astigmatism between the two groups, we can see from on all post-op days and all follow-ups, the SIA has been lesser in the 2.2 millimeter group as compared to 2.8, and the data has always been statistically significant at all follow-up visits. This is a line chart showing that there is a difference between the two groups, and it is statistically significant at all follow-up visits. Discussion: cataract as the leading cause of treatable blindness in the senile age group in India, and patient undergoing phacoemulsification surgery with IOL implantation have high expectation of early visual rehabilitation, glasses-free post-surgery, and sufficiently clear distant vision. The study involved 300 patients undergoing phaco, comparing the 2.2 millimeter and 2.8 millimeter incisions. Mean ages were similar, and there was no significant difference in gender distribution or eye laterality, which was similar to the studies carried out before. Both groups showed significant enhancements in uncorrected and best-corrected visual acuity post-surgery. The 2.2 millimeter group demonstrated slightly better early visual acuity improvements, though the differences were not statistically significant in the later follow-ups. The 2.8 millimeter incision resulted in higher SIA, indicating statistically significant changes in astigmatism compared to the 2.2 millimeter incision at all postoperative time intervals. The findings of this study provide valuable evidence for optimizing surgical techniques in improving patient outcomes undergoing cataract surgery, emphasizing the significance of preferring smaller incisions to minimize surgical induced astigmatism. So in conclusion, we like to say there was no statistically significant difference in age, gender, and eye dominance, ensuring a balanced comparison. Postoperative UCVA and BCVA was similar between the two incision sizes, so both the groups had a similar long-term visual recovery. Our findings suggest 2.2 millimeter incision induced a lesser amount of SIA as compared to 2.2, which was statistically significant at odd follow-up visits, thus reducing the size of incision from 2.8 to 2.2 has a significant effect on SIA. Thank you.
So how much was the difference in actual terms in astigmatism between the two groups? What was the cylindrical power? What was the mean cylindrical power between the two groups? Comparison and significance is different.
Yes, ma'am.
But what was the actual value like?
Ma'am, in 2.2, it was 0.34, and in the 2.8 group, it was 0.57, the mean in the 150 patients.
Which kind of astigmatism you get after the cataract surgery, like with the wound or against the wound, or what you call with the rule, against the rule? Against the rule. Did you ever apply any the suture?
No, sir, no sutures were applied. All the cases in which complications occurred or sutures were required, they have been excluded from the study.
Did you have any problem entering the incision with 2.2? If your sleeve and everything is normal? No?
So the surgeries were performed by a senior surgeon, so
Very good, very good.
those were not considered.
Thank you very much.
Thank you, sir.
तो 10 बजे खत्म हो जाएगा, 9:15 बजे खत्म हो गया, एक और है ना, डॉक्टर अर्णव सिंह सरोया आ गए हैं ना, आइए आइए आइए, स्वागत स्वागत स्वागत।
Presentation. Eight 9:45 बाहर अपलोड हो गया बाहर प्रीव्यू रूम में अपलोड मेरे को यही लेक्चर आ रहा है नहीं बाहर प्रीव्यू रूम में अपलोड ही है मुझे तो जो आ रहा है फ्रेश क्या करना सर
Your turn up, please start.
I'm not giving for that. I'm not here
So
it
the
for
uploaded says
fully,
not coming.
so I'm not marking it. Open this one, na? दे दिया मैंने. चलो.
सर ये सुनिए ये इस
Please look.
Original. Out of them, mark segment wise, content, presentation, slide, original. And then total.
anybody A very warm good morning, everyone. Without further delay, I would start with my topic. My topic for the presentation is glue dial. So as we begin, I'd like to start from the indications which we come across in daily practice. Starting from posterior capsular rupture, zonular dialysis, subluxated lens, progressive systemic conditions, nucleus drops, IL drop, or even endothelial keratoplasty or penetrating plasty with an unstable bag. Starting from the basic instruments that are required for the glue dial surgery, basic vitrectomy set of 23 gauge, glue dial marker, glue dial forceps, a trocar AC maintainer, 3-piece IUL of your choice, and fibrin glue, or can be done with sutures. Once a complication has occurred, how we start is first we suture the wounds if it's a phaco tunnel or an SICS incision, followed by the insertion of a trocar. According to your choice, it can be an anterior trocar AC maintainer or a posterior chamber, posterior trocar. Starting from the steps, in a very stepwise approach, we start from the scleral flap marking. This is done with the help of a scleral flap marker, which helps in exactly identifying the scleral flaps 180 degrees apart, which is followed by making of partial thickness scleral flaps using a crescent blade about 2 by 2 mm. This glue dial offers an advantage that it can be performed horizontally like temporal or nasal or vertically in case of excessive white to white. This is followed by making of sclerotomies below the scleral flaps using a 22 gauge sclerotomy needle, making sure that when we enter with the sclerotomy needle, we should not hit the iris, otherwise it might cause iris bleed. So we should make sure that when we are entering the eye, it should enter vertically down and then make it horizontal once we have a giveaway or a loss of resistance, as shown in the video. This is followed by insertion of the vitrectomy and thorough anterior vitrectomy or pars plana vitrectomy if desired. This is followed by an easy insertion of a 3-piece IOL through the phaco tunnel or the SICS tunnel using a 3-piece foldable or a non-foldable IOL. While insertion, we should make sure that we are following a sign which is known as the lucky 7 sign, in which we hold the first leading haptic with the MST forceps, and once we have a good grasp of the leading haptic, it is brought out through the sclerotomy, sclerotomy space. This, once we've externalized the first leading haptic, this is followed by something called as a handshake technique, in which it can be assistant dependent or non-assistant dependent by using two MST forceps, in which the trailing haptic is transferred from one hand to the other hand without any damage to the haptics or kinking of the haptics. This is followed by externalization of the second haptic outside the eye. As shown in the video, we first grab hold of the first haptic, followed by transfer of the haptic to the other hand, and then we take the first MST forceps through the sclerotomy and externalize it. This is followed by a formation of the interscleral chariot tunnels using a 26 gauge needle under the scleral flaps and followed by the haptic tucking into this Gabor chariot tunnel. While doing the haptic tuning, we should make sure that it is in circumference to the limbus. If it is outwards, it can distort the haptics and cause mild kinking. This is followed by the addition of fibrin glue, which helps in proper sealing of the scleral flaps as well as the conjunctiva. This is followed by the hydration of the wounds, or if desired, we can always make sure that we are closing it under suture. This is the post-op image that we usually get in a non-complicated or even in complicated cases, making sure thorough vitrectomy and wash is done. So in summary, the first step is we should first suture the wound so there is no excessive vitreous leak or trapping of the vitreous in the wounds, followed by placement of an AC trocar, maintainer or posterior trocar infusion, fashion out scleral flaps as desired, followed by sclerotomies, anterior vitrectomy, externalization of the 3-piece haptic IOLs, tucking of the haptics in the Gabor chariot tunnels, followed by insertion of pilocarpine to make sure that the pupil is round and circular, and close it. Thank you, sir.
Doctor, it is just technique which they accepted this is the technique. You don't compare with other techniques of the secondary IOL. So it is just a technique, it's good enough.
Yes.
Tell me the one biggest drawback of the glued IOL. Does it have a life? Does it carry risk of some kind of serious infections?
So as long as we have done hundreds and thousands of patients, the infections only if...
Not infection, I'm not talking of infection. Because you are covered it completely.
Yes.
So scleral flap must be covered. I do secondary IOL, but with the scleral fixation,
Yes.
is sutures. And then cover completely. So there is no extrusion at all of the loop.
Yes, sir. Yes,
That
sir.
was
There
the
is-
biggest complication of extrusion.
Yes, sir.
So but glue has a life. It can melt away and it can fall down. What I'm saying is just, if you could have compared with other technique of the secondary IOL,
Yes, sir.
there will be no it is better or not. You
Yes.
describe the technique, this is no technique.
Yes.
You have done it well, your guide or whatever, Masterji has done well.
Yes, sir.
So technique is sound, but it has a drawbacks
Yes.
compared to the scleral fixation. Of course, there are many which fix them inside only, without opening.
Yes, sir. We can just suture the flaps as well,
But,
making sure that the...
Anyway,
haptics-
a good one. So glued one, IOL is all right. And
The cost of the glue is one factor, so that is...
it carries the cow disease and all those, so many things, HIV and the glued IOL have been found to carry some kind of viruses which are not detectable even in your labs so far. So, but technique of course is done, this technique is done.
Yeah, there are other people who do a lot of glued IOL. At least you should have compared your results with them. That is one thing. Another is like you have told externalize first haptic.
Yes, ma'am.
And then you can use the second haptic. But you definitely have to make sure somebody is holding the already taken,
either we-
or put one
Plastic tag.
plastic tag
Yes,
kind
ma'am.
of thing. Otherwise, definitely it slips.
Yes, ma'am. If possible, the assistant can hold using a McPherson,
Correct.
or we can put a like we use a IV tube cuttings
Exactly
to just
that,
use
and
it
then
as a
put
tag.
it as sleeve kind of a thing so that it holds.
Yes, ma'am. With time, it does come a little easy, but
it
in the
does
beginning,
happen,
it
but
does.
still, when you are trying to
It's always
get
better.
the MST through the things, it can happen.
Yes,
That is one thing. Yeah.
Dracor, cannula or anything, anti-chamber maintainer, standard one really for all, I virtually advocate it for any kind of surgery, even this secondary IOL also.
Yes, sir.
Because your chamber remains well
Yes.
and your vitrectomy should be thorough.
Yes, sir.
That is what is very important.
Yes, sir.
And of course, vision and all that depends on so many macula and all that things. But technique is accepted.
Yes.
Thank you so much.
Thank you, sir.
Arnab, you didn't show us how you put the haptic in the tunnel after exteriorization.
Okay, sir.
How
I do
did
have
you-
it in the video. Actually, there was some problem in some of the videos being played. So what we do is we use a normal 26 gauge needle and through close to the limbus, as close to the limbus and as close to the sclerotomy space, we make like a horizontal incision parallel to the limbus, and using a McPherson forceps, it is guided into the gabachariatum.
Since you are showing all steps, this step has not
Yes,
been
I
shown.
think it's maybe
there?
skipped in. It's there.
Okay,
Sir.
okay.
It's there.
And it's very difficult to show a technique which takes more than half an hour to show in 4 minutes. It's really difficult. Okay, thank you.
Thank you.
बेटा डॉक्टर सिल्वर का आधा कागज दे दो, सबको दे दो ना. Give us all the paper. Given.
So can I now invite Dr. Simran to present regarding overcoming post-operative hurdles, managing challenges after phacoemulsification in UAT cataract.
Good morning, one and all. I'm Dr. Simran, junior resident from MGM Navi Mumbai, and I'll be sharing with you how we overcame post-operative hurdles after phacoemulsification in a uveitic cataract. Uveitic eyes account for approximately 1.2% of all eyes undergoing cataract surgery, and managing cataract in such patients is often challenging due to chronic inflammation. Furthermore, the corticosteroids commonly used to control uveitis can inadvertently accelerate cataract formation. Case report. A 50-year-old male presented with gradual painless vision loss in both eyes over 3 years associated with on and off redness. Patient was a diagnosed case of chronic uveitis under treatment and denied any history of trauma, infection, joint pain or any systemic illness. On examination, visual acuity in right eye was HMCF, PL positive and PR accurate, while in left eye was finger counting at 3 meters. On examination of both eyes, conjunctiva was congested, cornea had fine keratic precipitates, anterior chamber was shallow in the periphery, there was annular posterior synecdoche, dense cataract, and IOP was 10 millimeters of mercury. Fundus details could not be seen, and USG-B scan was within normal limits. The patient was planned for right eye phacoemulsification. The synechial adhesions were released through the side port. Pupillary dilatation was achieved through iris hooks. The cataract was then emulsified and there was implantation of hydrophobic intraocular lens. The surgery was uneventful and patient was started on topical steroids and antibiotics. This is how the patient's eye looked at POD1 with minimal edema in the cornea, well formed and quite AC. At POD10, the visual acuity was 6/18. At POD 30, patient complained of sudden diminution of vision. On examination, visual acuity was 6/36, cornea was clear and anterior chamber was quiet. Dilated fundus examination was suggestive of macular edema, which was then confirmed by OCT. CMT was 568 microns, for which intravitreal triamcinolone was administered. At POD 38, there was further decline in vision to 6/60. Anterior chamber was shallow in the periphery. There was annular synecdoche and IOP was 24 millimeters of mercury. The patient was started on anti-glaucoma medications alongside topical steroids and antibiotics. At POD 49, the visual acuity further declined to figure counting at 2 meters. There was microcystic edema in the cornea. Anterior chamber was shallow and there was iris bomb formation with IOP of 40 millimeters of mercury. Along with anti-glaucoma medications, patient IOP was managed conservatively using intravenous mannitol and glycerol. Despite the conservative management, IOP consistently remained above 28 millimeters of mercury. Therefore, NDAG laser peripheral iridotomy was done at POD 52. At POD 68, the visual acuity had improved to 6/12, cornea was clear, anterior chamber was normal depth, IOP had reduced to 10 millimeters of mercury, and cystoid macular edema had also reduced with a central macular thickness of 120. On subsequent follow-ups, IOP was maintained within 10 millimeters of mercury with visual acuity continuing to be 6 by 12. Patient was planned for left eye phacoemulsification with hydrophobic IOL implantation. And in this case, in the other eye, intraoperative prophylactic peripheral iridotomy was done to prevent post-operative rise in IOP. At 4-month follow-up, the visual acuity in right eye was 6 by 12, while in left eye was 6/9. Anterior segment was within normal limits. IOP was maintained in the within normal limits, and it was below 10 millimeters of mercury. And fundus examination was within normal limits. So uveitic cataracts are typically complicated by presence of posterior synecdoche and poor pupillary dilatation, necessitating intraoperative pupil manipulation to achieve dilatation. These manipulations exacerbate post-operative inflammation, increasing the risk of CME, elevated IOP, and PCO formation. In our case, while we planned the other surgery for the other eye, we planned an intraoperative prophylactic peripheral iridectomy to overcome the hurdles that we had experienced in the previous eye. So in conclusion, perioperative operative control of inflammation is necessary using topical steroids in cases of uveitic cataract that we all know. But also we can, in this case, we achieved benefits by doing the peripheral iridectomy in the other eye. Under the iridectomy was pretty large in size, and it was done under the steroid cover, which reduced the post-operative chronic inflammation. Other than that, hydrophobic implantation, hydrophobic lens implantation was also considered to reduce the inflammation. So addressing the dual aspects of inflammation and cataract formation is the key to successful treatment in uveitic cataract. These are my references. Thank you.
Why you thought that iridectomy should not be done in first case? In all these cases, when you have mostly you get the peripheral synechia or the posterior synechia?
Posterior synecdoche, sir. In this case, the posterior synecdoche was present, but there was already a lot of inflammation. So in the first eye, we did not...
There must have been iris Bombay and then you got the posterior synechia and all that. What I'm saying is iridectomy is better must in all these patients.
Yes.
Mixed steroids preoperative.
Yes, ma'am. After at presentation, the patient was immediately planned for surgery because of an emergency. But for the other eye, the patient was started on on oral steroids prior to the surgery, and even topical steroids were given. Thank you.
आप ही बुलाइए भल्ला साहब तो senior person, very active person, and he was head of the eye department at the Deen Dayal Upadhyaya Hospital in Delhi, Delhi Government Hospital. So, very good surgeon and very good person and very good friend. Thank you.
Thank you.
Come,
Thank you.
please.
Should I start, sir?
Please.
Good morning, everyone. The topic I am going to cover today is changes in astigmatism and higher order aberrations of total anterior and posterior corneal surface after 2.2 millimeter versus 2.8 millimeter phacoemulsification surgery. We all know that after cataract surgery, it is not only the quantity of vision, but also quality of vision, which can be deteriorated by both lower order aberration, which includes spherical errors and astigmatism, and higher order aberrations, which include spherical aberration, chromatic aberration, trefoil, tetrafoil, coma, and oblique decentration. But by adequately correcting both lower and higher order aberrations, optical side effects can be decreased and visual quality can be improved. Astigmatism and higher order aberrations can be diagnosed by investigating machines like rotating sheen flux camera, pentacam, or Sirius, and thus we thought we can compare pre and post operatively in different cataract incision sizes. What are ocular aberrations? They are actually deviations of wavefront exiting the eye from a chosen unaberrated reference wavefront. Lower order aberration extend from Zernike order 0 to second order, and higher order aberrations above the second order. So these are the lower order aberration: piston, tilt, astigmatism, and spherical errors, whereas the higher order aberrations start from above second order, that is trefoil, coma, tetrafoil, secondary astigmatism, and secondary spherical aberration. You see, these higher order aberration, even after you have achieved good quantity of vision 6 by 6, but the quality can be deteriorated by these higher order aberrations, and so we need to do something about them. Trefoil and coma are significant higher order aberrations. And these aberrations, unfortunately, cannot be easily corrected with non-invasive procedures or devices such as spectacles and contact lenses. So best is to prevent development of these higher order aberrations. And these aberrations can be measured by aberrometers, which can be outgoing and ingoing. And so our aim was to assess changes in these higher order aberration of total anterior and posterior corneal surface after 2.2 millimeter versus 2.8 millimeter cataract incision surgery. So we undertook this study in 300 patients of around 18 months from November 2020 onwards, and it was a prospective interventional randomized comparative single-blinded study which was done in Department of Ophthalmology, Deen Dayal Upadhyay Hospital, New Delhi. So these were the exclusion criteria: patients having any ocular disease, patients with previous history of ocular trauma, ocular surface disorders, or patients who were uncooperative for Scheimpflug segment imaging testing. And all these patients underwent complete ophthalmological examination, and they were operated by a single surgeon and followed up over a period of 3 months. And we divided these patients into two groups. Group 1 underwent 2.2 millimeter incision, and Group 2 underwent 2.8 millimeter incision. And not only the pre-operative measurements were taken, but also post-operative measurements of these higher order aberration were taken at first week, third week, 6 weeks, and 3 months post-operatively. And these were the statistical methods which were used. The independent sample t-test and other statistical tests were done, and so we arrived at these results and observation. So this is the depiction in the chart form of anterior corneal astigmatism at 2.2 millimeter versus 2.8 millimeter at 3 millimeter and 5 millimeter zone. Similarly, posterior corneal astigmatism was compared, spherical aberration of anterior corneal surface was compared, coma of anterior corneal surface was compared, and then trefoil of anterior corneal surface and spherical. Then we came to the posterior corneal surface, and all these aberrations were compared again. Spherical aberration between 2.2 and 2.8 millimeter, coma in posterior corneal surface between 2.2 and 2.8 millimeter, trefoil, and was also compared between these two incisions. So what were our results? We found that although both anterior and posterior corneal astigmatism increased after phaco surgery, but they came back to pre-op level by 6 weeks. And difference between 2.2 and 2.8 millimeter were not significant in anterior surface, but they were significant in the posterior corneal surface as far as astigmatism was concerned. And spherical aberration, there was hardly any change between the two groups. But what was significant was that there was increase in magnitude of coma at both anterior and posterior surface immediately after surgery. Similar thing was found in cases of trefoil. And we found that this was much more in 2.8 millimeter as compared to the 2.2 millimeter at both 3 and 5 millimeter zone. And these were the studies which have been done earlier, and they've also found, since there is no way to correct, better ways to decrease the incision size from 2.8 to 2.2 millimeter so as to increase the quality of vision after phacoemulsification surgery. So what we found was, although there was increase in posterior corneal astigmatism, but it was not statistically significant. But what was significantly important was that increase in higher order abrasion was much more in trefoil and coma, in much more in 2.8 millimeter compared to 2.2 millimeter group. So these just changing from 2.8 to 2.2 millimeter incision can yield better visual outcomes, especially in the early post-operative period. So what I feel is, we should not only promise patient quantity of vision, we should also promise patient quality of vision, because so many of these patients having gained 6 by 6 vision are not totally satisfied, because the quality of vision which they found is not very good, and they keep on complaining. So to decrease the number of these dissatisfied patients after cataract surgery, I think we should also lay significant stress on improving and decreasing higher order aberrations after the cataract surgery. Thank you, everyone.
Session, and I would like all people to have group photograph. The presenters also. The presenters also, please come here. Photo लेने वाला है भाई कोई? आइए। याद रहे जिंदगी में थोड़े से बच्चों के साथ हमने क्लास में बच्चे हमारे पीछे आ जाए चाहे चलो जैसे आपको बेटे पीछे आ जाए अच्छा चलो ठीक है बिल्कुल